An approach to understand thoracic and lumbar fractures. First, I would like to set up some basics about terminology that we are going to use. And first, what are the anatomical, biomechanical characteristics of this area? It's formed of three parts, three biomechanical regions. The first part is from D1 to D8, which is relatively rigid, presenting kyphosis, and it is fixed by the rib cage. Flexion injury pattern usually predominates from D9 to L2. It's called the transitional zone or thoracolumbar area, where most of the fractures of the thoracic and lumbar area occurs, and it is a transition zone between immobile segment and mobile segment out of the lumbar area. It's a transition between a kyphosis and lordosis. The third part, which is from L3 to the sacrum, and it is mobile, usually it's lordotic, and it's subjected to axial load injuries more than flexion injuries. Why flexion injuries are predominate in the thoracic area? Because a body weight line passes through anterior to the thoracic spine, thus causing more wedge fractures, while in the lumbar area it passes through the posterior part of the lumbar vertebral bodies behind the vertebral bodies, so it causes more burst fractures. In discussing thoracic and lumbar fractures, we have to address some points, which is the incidence, mode of injury, mechanism of injury, classification, and the management. Most of the injuries can be caused by trauma or pathological. Traumatic injuries usually occurs from motor vehicle accidents in 50% of cases. Falls represent 25% of cases. Gunshot injuries 15%. Sports injuries 10%. While pathological causes could be due to infection, tumor, or osteoporosis. Most of the patients with a spine injury have an associated injuries. 80% of spine patients, they have multiple injuries. Either 26 of them have head and face injury, 16% represent with major chest injury, 10% represent with major abdominal injury, and 8% represents with long bone or pelvic fractures. Here is an X-ray showing a burst fracture of the dorsolumbar area, and it is associated with fracture calcaneum. Usually it is from an axial loading injury. So when we talk about the incidence of thoracic and lumbar in spine injuries, fractures, it's 70 per 100,000 population. 70% of them occur at the thoracolumbar area between D10 and L2, usually associated with multiple injuries, and 50% of the flexion distraction injuries which occurs at this area are usually associated with visceral injuries. Most of the fractures which occurs at the thoracolumbar area, 15% of them, they are associated with neurology, while 60% of cases with dislocation will have presenting with neurology. Male-female ratio is 4:1, and Y is more favorable neurological recovery for fractures of the dorsolumbar area without dislocation, because the size of the spinal canal of the spinal cord in relation to the spinal canal is much wider. Vascularity is better below D10. Usually the lesion which comes at this area is incomplete lesion, and coda equina nerve roots below L1. Why neurology is less common in the lower lumbar area and fracture spine is rare is relatively uncommon in the lower lumbar area. We mentioned before that the axial loading axial loading and line of body weight passes behind the lumbar spine because of the lumbar lordosis. And if the lumbar area is subjected to a major trauma, it usually doesn't result in fracture of the spine, because the increased size of the disc, which absorbs axial loading better, increased size of the body, which sustains more stresses, and the orientation of the facets changes from the frontal to the sagittal plane, so fracture dislocation is less than the thoracic area. And the L4 and L5 bodies are anterior to the weight-bearing line, and the greater force is needed to fracture L5 and S1. 80% of a canal compromise can be seen without neurology in some patients, because most of the nerve roots here are comprising the coda equina. So what is instability? Instability is a supraphysiologic spinal movement that occur under normal physiologic loading condition due to insufficiency of the supporting structures. So there is a possibility of damage to the spinal cord, or damage to the nerve root, or resulting in incapacitating deformity, or resulting afterwards in severe pain. That's why we have to clarify that we have two instabilities. We have mechanical instability, and we have a neurological instability. For example, if we have a growing child and with a fractured dorsal spine which is mechanically stable, and he has a complete neurological injury, so surgery is a solution for such a child, because he has a possibility of growing and possible development of kyphotic deformity, while if the same injury occurs in an adult and it is mechanically stable with complete neurological injury, we may go for conservative treatment. The example is, if there is a minor fracture of the dorsal spine and there is multiple rib fractures and there is no neurological injury, so the decision will be surgery. Why? Because it is unstable fractures, because the rib cage was broken, and he will develop significant deformity. What is the mode of injury? We have different mode of injuries, which is axial loading force. Axial loading force at the thoracic spine may result in compression, resulting in wedge fracture, while in the lumbar area, because it passes behind the vertebral body or through the middle column, it will result in burst fracture. We have rotational and shear force, and we have flexion distraction force, or combination of any of these forces. This is an example of the compression force, and this is an example of the rotation. Okay, management of a patient with fractured spine. The aim is to retrieve the patient from the site of injury safely and rapidly, and transfer to a suitable facility. And they may be transferred wrongly, so they may deteriorate because of improper immobilization. Fractured spine should be suspected in all unconscious patients, and high energy trauma, evidence of neurological deficit, and multiple injuries. We will have history about the mode of injury and the position of the patient when found, and whether he was putting the seat belt, and we'll see if there is paralysis. Inspection. All clothing should be carefully removed. Any bleeding, abrasion, limb asymmetry. We have to know the anatomy of the spinal cord. We have corticospinal tracts and the spinothalamic tract, and the gracile and the cuneate tracts. these can be clinically addressed. Each of them have a lateral part and a ventral part. A hand is represented medially, while the foot and the sacral area are representing lateral. Neurological examination, we have to know if he is intact, complete, or incomplete. What means by complete? There is no motor or sensory or sacral sparing preservation below the level of the injury. Incomplete means there is preservation of any movement below the level of injury, or there is a sacral spare, or there is sacral sparing. We have to know the definition of a myotome, and as well as what means by a dermatome. Neurological examination involves sensory evaluation, motor evaluation. We have two classification system, which is a Frankel grading system. E is intact sensory and motor, while A is complete loss of sensory and motor function. It doesn't state the neurological level, it does state bladder and bowel function. Asia grading is more or less the same. It is grading also from A2. Sacral sparing means perianal and perineal sensation, rectal tone, big toe flexion implies partial structure continuity, may be only evidence of incomplete injury. We have to know what is a complete and what is the incomplete. Incomplete preservation of sensation in S4 distribution and voluntary control of spinal cord injuries. As the thoracic region means cord lesion, while in the lumbar area it's coded. We have four different syndromes, which is the central cord syndrome is the worst, which can occur at the thoracic area. We have we have the anterior cord syndrome, and we have the posterior cord syndrome and Brown syndrome. We have the pulpocavernosus reflex, which means that end of the spinal tract. Reflex, which is absent, means upper motor neuron lesion. Cord lesion or unilateral absence suggests lower motor neuron. Here are some examples on how to diagnose plain X-ray, which is, we can see here, flexion distraction injury, bony chance fracture passing through the body and the spinous process. Here is the compression fracture, here is fracture dislocation of the spine, and here is widening of the interpedicular distance, meaning that the middle column is. CT also help in injury suspected on plain films. MRI available for assessing cord and soft tissues, associated disc herniation, hemorrhage versus edema, ligamentous tear and facet capsule disruption visualized with fat substance. Three classifications that address fracture stability, neurological injury, late deformity, or then a three-column system doesn't address, or the load sharing classification doesn't address the neurological status, while the telic system complex is the formed of the ligamentum flavum, interspinous ligaments, supraspinous ligaments, and the posterior and the facet capsule. Load sharing classification, it involves the degree of comminution, apposition, and radiographic criteria for instability. It's kyphosis more than 20, loss of more than 50% of vertebral body height, multiple adjacent compression deformity, spinal dislocation of the posterior elements, bony retrobulsion to spinal canal with more than telic system. It is the clinical patient examination with it is a mood point system. Compression takes 1, distraction 3, translation and rotation 3, neurology incomplete 3, while complete 2, nerve root 1, stability, ligaments PLC either intact or injured. According to the stability spinal column, anterior takes 1, middle 1, and here we can combine between the radiology and the neurological status of the patient. decision making. If fractures takes 3 points, we have non-operative treatment. If fractures more than 4 points, non-operative treatment versus operative treatment. Fractures 5 points or more for surgery. This patient is an example. It takes this compression burst fractures on middle and middle column, PLC, no injury, it will go for conservative treatment. Approach selection: if it is neurologically intact, ligament injury present, so posterior alone. Whether to discuss it is it anterior versus posterior or combined, this will be the issue for another lecture. Take-home messages: all fracture patterns with an element of rotation or distraction are considered unstable. PLC is the key for stability. Helix and the load-sharing classification point system is the core for classification treatment approach. Fractures may display characteristics of one or more of these injury mechanisms.